So we are live now.
Hi, good evening. It's a pleasure and honor for the Bombay Opthal Association to welcome all of you all to this very special meeting. It's actually a proud moment for all of us that 11 of our ophthalmologists have won roles at the ASCRS Golden Globe Best of the Best Video Awards. And
Dr. Vivekanand, good evening to you. And Dr. Bharti, good evening. Thank you for joining.
Good evening, sir. Thanks for inviting me. May I request our President, Dr. Himanshu Mehta.
Dr. Vivekanand, you want to check your slides quickly? We are starting in 1 minute.
Sir, I have the video.
I can't hear you. You are on mute. Hi, Deepak.
Hi, sir. I think we are already live.
Sir, we are live. Himanshu sir, we are already live, sir. We are live now.
Himanshu sir, we are live. We are on.
Okay, Manish.
Yeah. So once again, it's honor and privilege for Bombay Opthal Association to be hosting this very special meeting because 11 of our ophthalmologists have made us really proud.
Manish, you can't be heard. Manish, you are on mute.
Am I heard, Navneet?
I think we can hear him. Dr. Himanshu.
Sir, there's something wrong with your audio, Himanshu sir. Rohit sir, can you hear me?
Yeah,
Manish can't hear you.
I can hear. Dr. Himanshu, your audio is not working.
We can hear well.
We can hear it.
Everyone is able to hear me, sir. आपका audio कुछ issue है.
Continue, Manish.
Yeah.
We can hear you.
Right. So, like I was saying, that it's a really proud moment that 11 of our ophthalmologists have been honored at the ASCRS by the Golden Globe Video Awards, and we will be actually felicitating them, and we'll be seeing the videos that have got us those awards. And I would request our President, Dr. Himanshu Mehta, to take things forward. Himanshu sir, could you please take things forward?
Thank you, Manish. Thank you so much. After an exhaustive journey to the US and Alaska, welcome back to India.
Thank you, sir.
So I think I'd see that the last time you shaved was in Alaska, not in Bombay.
Yeah.
Welcome back to Grand Reality. And thanks, friends. This is a wonderful session that we have. It's a very proud moment for Bombay Ophthalmic Society to have this meeting here. It was a very proud moment. I was there present in San Diego when this event actually happened. And to see that one after the other, more than 10 people from India getting a prize was an amazing feat that I have never witnessed before. What spirit, what bonding, except the flag of India which we are missing. There was everything else which was there to make India proud.
Next time we'll pack one for you, sir.
Yes, it was just super to see in every possible faculty we had prizes coming up. And that's what the best part is. So the session here has been organized for everybody to see some of the best films which have won the awards internationally. And most of these people who have won are in a regular habit of getting prizes everywhere. I was just talking to Rohit right now, and his son in the APSCRS has got another gold medal there also. Congratulations, Rohit, and very proud of you and all the things. But one thing that we want from all of you, what is common is what we're going to kind of measure, that what is it that made you get the prize, and what was the deep feeling? Why did you get into this at this level, and how long back did you start? And this is something which we are going to be listening to very carefully, because that's a learning session for all of us. That is so very important. What made it? How did you go about with it? And what was the best way that others can learn from here? And this will take you to a lot of places. We've been waiting for Dr. Lahane, who has been a cornerstone for Bombay Ophthalmic Society to progress to this level. He should be joining in a minute. He's with a patient. I just spoke to him. Dr. Sumit also has been the backbone. I must thank Dr. Rohan and Pooja for getting this thing organized so well and coordinating with everybody and getting the graphics done and the whole presentation. Thank you so much, Pooja and Rohan. We start quickly because we have 10 minutes per speaker, and you're going to enjoy the feast which is coming. An absolute feast to your eyes. Everything which is going to be said is so very important. And if it's the international level they have been recognized, there is a lot to understand from that. Our first speaker, Dr. Veena, is not present at this moment in time. I would request Dr. Rohit Om Prakash to start with his presentation. Congratulations, all the winners, and very proud of you. Bombay Ophthalmic would love to felicitate you, and in person, we would have loved to have a meeting with you. However, let's start with what we have as of today. Over to you, Rohit.
Yeah, thank you, Dr. Himanshu, for coming out with the idea of honoring everybody. You were talking about India going great. I'll give you a very small example. It was a film festival award. Such in the ASCRS, such was the bombardment of Indian winners that Richard Packard called a German as Indian. And he said that there's such an invasion of India that for me, I thought that he's also from India. So that was the biggest, which one can ever think of. So should I share my screen? Yeah. So can you see it?
Yes, sir.
Yes.
So I would be showcasing a concept which I've been talking about for a long time, that is differential IOP, a new paradigm in phacoemulsification. So this was the video. A goal without a plan is just a wish. Considering that I wish to have a seamless experience with phacoemulsification every single time, what I really do, not just have a plan A, but I have a plan B and a plan C. If high IOP phacoemulsification doesn't work, having the same low IOP settings doesn't always work either. That's where plan C of differential IOP comes in. We use high IOP or high bottle height, which gives the advantage of a non-fluctuating anterior chamber. But high IOP phacoemulsification is like a double-edged sword where negatives outweigh the positives. For instance, wipeout syndrome in advanced glaucoma patients, painful procedure in patients with high baseline IOP, larger anterior chamber depth, and greater axial length. There's a higher incidence of lens iris diaphragm retropulsion syndrome in myopes and vitrectomized eyes. There is compromised anterior segment with increased decimatous folds, more anterior segment inflammation, and more edematous corneas. There is difficulty in short eyes. There is stress to the zonules, anterior vitreous phase rupture, even with an intact posterior capsule. Will plan B of having low IOP work in these scenarios? Yes. Decrease flow rate corresponding to the IOP and you have a stable chamber. Let's simplify plan B of low phacoemulsification. There is physiological IOP settings with IOP between 18 millimeters mercury and 22 millimeter mercury with low flow rate of 23 cc per minute to 26 cc per minute. Supra-physiological IOP settings are IOP of 23 to 34 millimeters with flow rates of 23 to 35 cc per minute in different steps. Sub-high settings are IOP of 35 millimeter to 45 millimeter mercury with flow rates of 40 to 45 cc per minute. In advanced glaucoma patient, I'll be using physiological IOP settings. Side port incision is calibrated with the chopper for extra stability. You can see stable chamber throughout the surgery at physiological 20 millimeter IOP settings. There is no risk of wipeout syndrome. The case is closed with low IOP for this patient of posterior polar cataract with pre-existing defect. I'll use physiological IOP settings. There is stable chamber setting. There is no undue deepening of anterior chamber, no undue posterior bulging, and extension of posterior capsule because of high pressure. The low infusion of fluid doesn't push more fluid into the vitreous, thereby not hydrating the vitreous. Minimal pressure difference between anterior segment and posterior segment is making the nuclear fragments float in anterior segment without being pushed posteriorly. You can see that the size of posterior capsular rent has remained the same. I will be using physiological IOP in this patient on tamsulosin with 5.5 millimeter pupil. Side port incision calibrated to chopper is created. Epinephrine injected for dilatation. Irrigation of handpieces while going in and coming out. Stable chamber settings with low fluidics helped decrease turbulence by reducing fluid streams and pressure variance in anterior chamber. Pupil size remained the same at the start and end of surgery. In this case of posterior capsular punch with phaco probe, I used supraphysiological settings. Here, stable settings with low IOP was used along with low parameters. There is negligible vitreous hydration and vitreous is not being drawn to the tip. Nuclear fragments were floating without being pushed back. Fragments have been successfully taken out safely. There is no extension of posterior capsular defect. In this patient of high myopia, I would be using supraphysiological settings. There is no excessive deepening of anterior chamber, no lens iris diaphragm retropulsion syndrome. The case proceeds as a normal case with decreased pain score felt by the patients. I would be using supraphysiological IOP in this patient of zonulopathy following capsular hook support. Low IOP with low fluidics and stable chamber settings are being used to decrease stress to the zonules, minimize additional zonular tear, and decreasing lesser fluid misdirection too. Yes, we have cracked it. Oh no, we are still missing a piece. It is time for plan C. Let's understand. There is a corneal endothelial protection with low IOP because of minimized mechanical trauma and OVD retention. However, low IOP phacoemulsification in physiological and supraphysiological IOP settings involve lesser anterior chamber and bag volume, causing more trauma to the corneal endothelium in hard cataracts with increased thickness and with low anterior chamber depths. We build a plan C of differential IOP phacoemulsification, a combination of supraphysiological and sub-high IOP phacoemulsification. I will use differential settings in hard cataract with increased anterior-posterior diameter and low anterior chamber depth. While sculpting, supraphysiological settings are used. IOP is increased to 44 millimeter for quadrant removal to increase inflow adequately. At this IOP, increased AC depth increases working space and decreases mechanical trauma. Since moderate fluidics are being used, turbulence in AC is not high. OVD is replenished for corneal endothelial protection. And this IOP is much below the closing pressure of central retinal artery. In this patient with hard nucleus, in white cataract with anterior capsular tear, differential IOP settings were used. Flap motility sign and safe phacoemulsification techniques with low IOP were employed. Low IOP and stable chamber settings decreased the chances of anterior capsular tear extension to become a wraparound tear. And if by any means the anterior capsular tear reaches equator, it doesn't allow fast posterior extension. Concluding, let's use a paradigm of different low IOPs, wherein different IOPs are used in different situations. Different IOPs are used in different steps to maximize patient outcomes. Thank you.
Rohit, brilliant presentation. Great amount of work and experience which is responsible for differentiating your plan A, plan B, plan C. You also have given a very nice idea about the flap motility, which if some for people, for a fast recap, is a sign which Rohit has introduced. That is the flat, Rohit, I would want you to explain a little bit.
Yeah, well, if there's an anterior capsular tear, and you are caught in a surgical dilemma, whether to continue or to convert. So in this condition, what comes into your help is the flap motility sign. You should see if the flaps of the interior capsular tear, if they are fluttering, if they are everted, this means it is pre-equatorial. And if by any means they are non-fluttering and inverted, this means it's a wraparound tear. So that is what is basically the flap motility sign. So this, differential IOP, using low IOP and settings, really changes the game plan in your surgical practice. Another important thing which I see which is happening is that we are coming across many patients who have had intravitreal injections. So these patients do have a posterior capsular tear also. So if you use low IOP and you treat the patient as a patient with posterior polar cataract with pre-existing defect, the probability of having a nucleus drop also decreases in these patients. So, using different IOPs in different situations really helps.
Yeah, it's a absolutely brilliant thing that we have noticed. If you have high IOP in certain cases, it can really mess you up, and if you have low IOP, it can really mess you up. Like classically a posterior polar, there is just not the perfect time where you're going to mess around. You don't want to have too much of visco, you don't want to have less visco. Either which way, the capsule could be in a bad situation. So great, appreciate a very well-known fact, and I guess to go through it again and again and to put it up in your practice in day-to-day would be a very practical help to see that you get into lesser complications than what you might have before. Thanks, Rohit. Thanks for sharing your wonderful video. What was the inspiration? What made you think in this direction, Rohit?
What I was seeing was that at times we were having, corneal edema in patients when low IOP was being used, and in hypermetropes where the anterior chamber depth was low. So I was using low IOP in all cases. Then we thought of, increasing the IOP, and we had the required results. So, just trying to introspect makes you realize that there is some folly, so that you innovate and you come out with new ideas.
Great. Thank you so much. Dr. Deepak Megur, you are next. And Deepak has been known to present some of the best videos on YouTube that you have. He is very good. He gives excellent narration. He's got some very best quality videos, and he goes into the depth of a lot of subjects. If you haven't seen his site, you can go on YouTube and see a lot of learning videos which are there, from photography to how to insert your pupil dilator and what have you. And here he comes out with one more magic up his sleeve. Over to you, Deepak.
Thank you, sir. Thank you. And let me share my screen now. This film is in. Is it visible now?
Yes. Yes, it is visible now.
The common perception is that more is always good. Is it always true? Let's find out. One fine day, I was doing this posterior polar cataract when I witnessed something extremely unusual. I'm injecting OVD inside the eye. It's the usual amount, but I witnessed something very rare. I could see this posterior capsule rupture happening during OVD injection into the antechamber even before the antecapsule was punctured. Well, I had not seen anything like this in my career. This was weird, and this really got me thinking. I dug deep into my video library and I got hold of 3 more instances of weird spontaneous posterior capsule ruptures happening in polar cataracts. In all these eyes, there is no contact of any instrument with the posterior capsule, but still a posterior capsule tear happened. Let us look at each of these cases individually and try to make some sense on why these things are happening. The first case, this is a 50-year-old myope with a classical posterior polar cataract. I'm injecting dispersive OVD first, followed by sodium hyaluronate, the classical soft shell technique. The OVD is not in excess, it's the usual quantity. But lo behold, I could clearly visualize this posterior capsule split happening, which was confirmed once the cataract was removed. Well, the case was managed pretty well eventually with good visual outcome. The next case, this was way back in 2011, a 25-year-old myope with a posterior polar cataract. I managed to remove the cataract without causing the posterior capsule tear. Now before going in for cortex aspiration, I've injected OVD inside the antechamber to prevent the antechamber from shallowing. I have religiously followed the commandment of never allowing the chamber to shallow. Now I enter the chamber with my bimanual handpieces. As soon as the irrigation kicks in, the chamber deepens and suddenly I can clearly see these 2 splits and 2 waves there. The first split is the posterior capsule rupture. The second split, the second wave is probably the anterior rupture. Again a young patient with posterior polar cataract. The cataract is successfully removed, so far no posterior capsule tear. Again at every stage OVD is injected whenever the phaco probe comes out to maintain the chamber religiously. Now I need to remove the cortex. Boom! Again the PC splits wide open. Mind you, there is no instrument touching it. Moving on to the last case, this is the weirdest of all. A young patient, posterior polar cataract. I've taken all the necessary precautions to minimize PC rupture. So far so good. And this time the cortex is also aspirated out and still there's no PC tear so far. I thought its job is done. The bag is filled with OVD and I go on to load my lens, and as soon as I'm done and ready to push in the lens, lo behold, what am I seeing here? A large posterior capsule tear is staring at me. Now what caused the posterior capsule tear in all these eyes? There's no direct contact of posterior capsule with any of the instruments. Well, let's try to solve the puzzle. So what is the common link in all these 4 cases apart from being posterior polar cataracts? Well, 3 out of the 4 patients were young, less than 30 years, and 2 out of them were myopes. These characters, young patients and myopic eyes, lead us to the common link, which is scleral rigidity. To be precise, all these eyes had low scleral rigidity. So what's the big deal about this? When we go back and analyze, a raised infusion pressure is the reason why the pathological posterior capsule split wide open. However, similar phenomenon of spontaneous posterior capsule rupture is uncommon in eyes with normal scleral rigidity. However, in eyes with low scleral rigidity, the sclera can stretch a little bit, which allows more fluid or OVD to accumulate in the eye, which eventually will raise the pressure inside the chamber, and the weak posterior capsule just gives way. So, what can we do in such a scenario? Well, in all eyes with posterior polar cataract, apart from all the standard prescribed precautions taken during surgery, one additional precaution needs to be taken. That would be just to decrease the infusion pressure at every stage in the surgery, from the time the OVD is injected into the eyes to the time the side ports are hydrated. In short, we need to be working on a principle of low flow, low pressure surgery. It's a simple philosophy. Now we'll put these principles into practice and see whether our hypothesis works. This is a young patient with a polar cataract. The OVD is put. The note that the chamber is underfilled, as is evident from the presence of the air bubble and the appearance of the corneal folds during incision. During nucleus aspiration, the bottle height is kept at 50 centimeters with correspondingly low flow rate and vacuum. The posterior capsule continues to remain intact. Similarly, while cortex aspiration, again please note the bottle height. We start with a low bottle height and it's increased subsequently once any antechamber instability is noted. Finally, the eye is maintained soft during IOL insertion, OVD removal, and even during side put hydration. We tried the same principle of low flow, low pressure surgery in the next 8 consecutive eyes of post-polar cataract in patients younger than 40 years. In all these eyes, the eye was kept soft during every stage of the surgery. The bottle height during nucleus aspiration was never above 50 centimeters, and during cortex and OVD aspiration, never above 70 centimeters. And in all these 8 cases, spontaneous rupture of posterior capsule was avoided. While in our series, this new principle of low flow, low pressure surgery, along with the old time-tested standard precautions, significantly reduced the incidence of spontaneous rupture of posterior capsules in young patients with post-polar cataracts. The moral of the story is short. More is not always good. Traditionally, we are all taught to be so obsessive of maintaining a deep chamber during surgery to avoid surge. We increase the bottle height, use pressurized infusion, use OVDs to pressurize the eye, but we can clearly see that this can be counterproductive in a select group of patients. So in these post-polar cataract patients with low scleral rigidity, I would say less is more. Less infusion, less pressure inside the eye at every stage, and that's the way to go. To conclude, low flow, low pressure surgery reduces the incidence of spontaneous posterior capsule rupture in these vulnerable eyes. So the next time, please do watch the bottle height. Thank you so much.
Okay, that was it, sir. That was it.
Thank you, Deepak. A great follow-up to the previous talk, Rohit, talking about pressure variables at multiple places, and this is classically seen in posterior polar cataract, where the posterior capsule has a mind of its own. A little more pressure, and even I've seen toward the end when you are closing the eye and you just filling up the cornea, that time the pressure increases and the posterior capsule has ruptured. So at every given point of time, we have to be very careful with the posterior polar cataract. The capsule is very, very gentle and delicate. You really have to be very delicate with that, even despite the best of the intentions, and without you touching any particular capsule and or the nucleus. Appreciate Deepak. Brilliant videos. I think it couldn't be made more easier and simpler. The fluid wave going was just beautiful. Very well picked up by a microscope and very well enacted here. Thanks so much.
Thank you
for that.
Thank you, sir. Thank you, sir.
We have a question from the audience, so we will come back to that. And Dr. Vivekanand, are you ready with your presentation? Then.
In the world of ophthalmic surgery, we encounter multiple challenging scenarios. These procedures can be incredibly difficult, requiring high levels of skill, precision, and experience. We wish we had a tool as simple and strong as this. We came across the gonioscopy-assisted transluminal trabeculotomy procedure developed by Dr. Davinder Grover and Dr. Ronald Feldman. In this procedure, the tip of a Prolene suture is cauterized to create a flange, which is then introduced into the Schlemm's canal, allowing a 360-degree trabeculotomy to be completed. This led us to the path of replacing the traditional knots with flanges. Now, just like Thor and his mighty hammer Mjolnir, we too have a powerful tool at our disposal, the flanges. Our first challenge was dealing with cases of large zonular dialysis or gross zonular weakness, such as in this microspheral phakia case, where a capsular tension ring alone.
Video is not playing.
Actually, it was at 752. We have to make it to 0 first.
We carefully completed the rexus and inserted the CTR. Capsular hooks were then used to anchor.
Sir, is it playing now?
Yes.
Sorry, sir. I didn't realize.
In the world of ophthalmic surgery, we encounter multiple.
You have to play it from the beginning.
Play it from the beginning and it's watch the video. Yeah, thank you.
I'll start it now.
Yes.
Beginning, sir.
Start again from the beginning.
Yes.
It's freezing. It's not playing.
Yeah, it's not
In the
playing.
world of
The audio is moving, but the video is not moving.
So let me just close and start again.
Yeah. Rohan, are you ready? You're next.
Yes, I'm ready, sir.
Okay. Question for Rohit. Rohit, for you, how much time do you get to switch from plan A to plan B? Okay, go ahead. Please start, Dr. Vivekanand.
In the world of ophthalmic surgery, we encounter multiple challenging scenarios. These procedures can be incredibly difficult, requiring high level.
Sir, is it playing?
No, it's not playing. The audio is coming, video is not coming. What we will do is, sir, can you just redo it on another one? We will come back to you again after the next speaker.
Sure, sir. Sure.
Yeah. Rohan, congratulations on being an early bird and one of the youngest ones to get a prize at such an early stage. Let's over to you, Rohan. Let's see your video and give us some more comments on how you thought about it. Sir, you'll have to get off the screen, Dr. Vivekanand. You'll have to
Stop sharing.
Stop sharing the screen. Yes.
It is a problem.
From yours, yeah, that's right. Thank you.
Your connection is unstable.
Yes, Rohan.
So basically, this video came into existence because of a problem that is very well prevalent, and all the literature points towards it, that the most common complication when it comes to smile surgery is actually when the dissection is happening and we cut the lenticule, or we go through with it, and we cannot extract that lenticule in totality, and becomes a total mess. So this basically video is to extract that lenticule in totality. And the reason why that is, extremely important is also highlighted in this video. So here's the video, and then we can have a discussion later.
For smile refractive surgery, the authors have no financial disclosure to make. Ever since the existence of human life, our aim as a united community has been to make things easier, and in order to do that, one has to constantly innovate. What is innovation? Innovation is the art, science, or process of developing better solutions from existing inventions and ideas. It is the validation and exploration of ideas that others may have missed, rejected, or long forgotten. Innovation connects the dots. Similar innovations have led the evolution of refractive surgery, from radial keratotomy to PRK and microkeratome, to now the latest on the block, SMILE. In SMILE surgery, the lower interface of the intrastromal lenticule is created with the help of the laser, followed by the upper interface of the lenticule known as the cap. Finally, a 2 to 3 millimeter tunnel incision, usually superiotemporal, is made to link the cap interface to the corneal surface. This is followed by lenticule separation with the help of a dissector and extraction of the lenticule with a pair of microforceps. Here, we demonstrate the separation of the lenticule and its extraction by pulling it out with the help of a microforceps. But not every ride is as smooth and easy. If one is not careful, we never quite know when it ends up in disaster. If we take a look at this particular case, there is a marked resistance in the separation of the lenticule, which leads to a tear of the hinge in the tunnel incision. This resulted due to improper dissection, followed by a tugging movement to retrieve the lenticule. Such complications are not uncommon. Going through the review of literature, there are multiple highly cited papers published in index journals showing lenticule extraction related complications making up for a majority of the total complications of smile surgery. This paper reports the complications of smile procedure with the study comprising 160 eyes and showing a complication in 43 eyes. Cap rupture during dissection was the most common complication in as many as 16.2% of the cases reported. So where did the idea originate? One day, I had a severe earache and I went to my ENT friend for a checkup. He told me that wax is the culprit for the earache and removed it by irrigating my ear cavity and not pulling it out, which got me thinking. If the ENT can do it, then why not use it in ophthalmology? So I took this idea to my mentor, Dr. Gaurav Luthra, and we developed a hydrocannula to extract the lenticule, making smile surgery further less invasive and extracting the complete lenticule without any cuts and tears. The hydrocannula is of 23 gauge and it bends to facilitate its movement over the contour of the cornea. The curvature of the cornea was taken into consideration while designing the cannula, and we have been using it for over 12 months now. We have done successful extraction of the lenticules in 196 eyes over this period. Here are a few demonstrations which show how a simple idea can make a huge difference in the reduction of complications in smile surgery. Once the proper dissection of the floor and the gap of the lenticule is done, the hydrocannula is introduced and the saline is injected, which aids in smooth retrieval of the lenticule. This lenticule is now placed on the cornea to show the intact edges of the lenticule. Another example of the same technique, which is simple and reproducible, leading to the extraction of the lenticule in totality without any cuts or tears. Let us further examine how this works. So we commence the injection. The purpose of slow injection is to promote free flow. Now, why is this important? To make this technique work, you have to localize pressure differential between the inside and outside. If you have anything blocking the entry side around the hydrocannula, you will get a closed space. The pressure throughout the volume will be uniform. You get lamellar flow coming out of the end of the hydrocannula, and that actually is going to generate reduced pressure inside versus outside. You can understand this if you think about the way an airplane wing generates lift. According to the Bernoulli's principle, the pressure is lowest where the fluid flow is fastest in lamellar flow conditions. In case we do not do a slow injection, a situation like this might come up. But here, the advantage one has is that there is good visualization of the lenticule, and we know the correct vector forces to be applied to remove this lenticule with the help of a forceps. Once we have understood the dynamics of the procedure, it brings us to our next question, which is, why is this lenticule so important? Over time, we have realized what the true potential of human tissue is. An artificially made clone of the human tissue will never be able to replicate what we can achieve by using an original human tissue. Way back in 2014, we started cryopreserving the smile lenticule for possible potential use in human subjects. And less than half a decade later, we started using it in construction of corneal stroma, therapeutic keratoplasty, keratoconus, and most recently in regenerative therapy. Who knows what the future holds and what new uses of the lenticule might come up in due course of time, just like the amniotic membrane and the stem cells, which have progressed leaps and bounds in human evolution, thus making it imperative that we retrieve each lenticule in totality without any tears and cuts, and we store it for possible future use, hence making our innovation extremely important and one that could possibly help many individuals for restoration of sight, leading us to call this lenticule my precious.
Thank you, Ron. that was a brilliant thing that you came up with. I think it opens up a different paradigm in smile surgery. A flawless execution, because if it's a lesser the number, the smaller the lenticular thickness, it would be quite difficult to extract the anterior and the posterior part of the lenticule. When you thought about it, what were the other difficulties that you faced devising a cannula? Before you made the cannula, what was it that came in your mind?
So the first thing obviously was, sir, that you thought that the hydrodissection cannula that we use in cataract surgery will work. But we faced a lot of challenges in that because of the curvature of the cornea. So it had to be shaped in a way that once you enter, that cannula has to sit on top of that cornea according to the curvature of the cornea. So that was one thing, that was one bend that we had to make. That was one challenge that we faced.
I think it's a path-breaking concept. Dr. Gaurav has been talking about it for 5 years now. So I would like, you were lucky to be with Gaurav.
Absolutely.
Because he has been talking to me, we have been very close, and he has been talking about this, hydro expression for the last 5 years. And I would like I think you were lucky that you were with Gaurav by coming out with such a beautiful video.
Absolutely.
Yeah.
Thank you. Dr. Vivekanand, are you ready? Dr. Lane, welcome, sir. Thank you for sparing some time. Dr. Lane, namaskar, sir.
Namaskar. Because I was unable to join, lastly I came Ragini's home. It was in between, and I downloaded the app and then joined.
Thank you for joining in.
I'm really sorry because I tried my level best. I was traveling, so I welcome everybody. You please go ahead. When it finishes, I will talk.
Okay, thank you.
Hello.
Yes, Dr. Vivekanand, we are waiting for you to switch on your video.
In the world of ophthalmic surgery, we encounter multiple challenging scenarios. These procedures can be incredibly difficult, requiring high levels of skill, precision, and experience. We wish we had a tool as simple and strong as this. We came across the gonioscopy-assisted transluminal trabeculotomy procedure developed by Dr. Davinder Grover and Dr. Ronald Feldman. In this procedure, the tip of a Prolene suture is cauterized to create a flange, which is then introduced into the Schlemm's canal, allowing a 360-degree trabeculotomy to be complete.
So the video is not moving. What we give you some more time. We'll have Dr. Kumar. Let's have the video going and the audio can be from you, because either it is the video moving or the audio moving. So we can have the video moving and you can give a talk.
Okay, sir. Okay.
Okay, Dr. Kumar, why don't you get in? Kumar, are you ready? Yes, thanks, Kumar. So Kumar has had multiple prizes over the years and he comes out with some lovely stuff ever so often. Thanks for participating, Kumar.
Thanks. Another good news, Himanshu, can you hear me?
Yes, I can hear you, Kumar.
So we got 4 awards even in the photography festival at the ASCRS. 2 were winners and 1 was runner-up and 1 was constellation extra prize. So that was the additional thing that we got in our pocket this year at the ASCRS. So it was an ophthalmic photography competition, and this was a video which won in the video festival, the film festival. So this is a demystifying. I was really confused between manual CCC and femto CCC. For doctors who don't have a femto, always feel that it's a robotic marketing gimmick, and it's always bad to have a CCC from the femto. So I actually demystified the confusion between manual and femto CCC. So let's see what I've done. The joke, demystifying the story of manual versus femto CCC. This story has 6 interesting parts: placement, size, shape, creation, centration, and strength. For perfect manual CCC, imprint on the corneal epithelium with the rhexis marker on the visual axis for accurate placement, and enhance this imprint with a drop of dye of methylene blue for a perfect guideline for a manual CCC. In Femto CCC, the laser ensures automatic scanning, detection and placement for a perfect CCC in the center of the bag. Ideal size of a CCC is perfect optic cover. In manual CCC, one has to follow the rhexis marking made on the cornea or the image-guided technology for perfect sizing. Femto CCC is customizable as to the size of the optic. Shape of the manual CCC is guided by chamber dynamics and shearing forces, and therefore a consistent shape is always a challenge. It can be oval, pear-shaped, orange-shaped, or even heart-shaped. The Femto CCC is always perfectly circular. Once marked with a rhexis marker, it's important to fill the anterior chamber adequately with viscoelastic till the pupil slightly dilates. Then follow the mark or the image-guided technology to make a perfectly circular round rhexis. But at times it tries to run away in different directions. In such scenarios, one can really rescue it with a microforceps. At times, the anterior zonules are weak, so there is no counter-traction. Here, a dispersive viscoelastic will help you get a perfectly round CCC. In special situations, like a manual CCC in hypermature cataract, use of a microrhexis forceps to nick the anterior capsule and release the intralenticular pressure. Aspirate the same and inject a dispersive viscoelastic to flatten the anterior capsule and create a rhexis. Another approach to create a spiral CCC in hypermature cataract to prevent an Argentinian flag sign. In creation of a Femto CCC in hypermature cataract, an additional step of staining the anterior capsule with a dye to make sure that the CCC flap is freely floating is quite essential. The creation of the Femto CCC in subluxated cataract is beneficial. One can move the CCC away from the area of subluxation. The CCC then is easily pinched out. Yet another case of subluxated cataract and the creation of the rhexis. In this case, we create a smaller rhexis which is away from the area of subluxation. After the cataract extraction, we place the IOL in the bag, which actually centers in the center of the bag, irrespective of where the CCC is really made. Yet another case of a Femto CCC in a subluxated cataract. Look at the ease of removal of the rhexis, inject the viscoelastic, and we create the space for the endocapsular ring. Femto has definite advantages in difficult cases like 16-cut RK operated patient. Look at the ease of the removal of the CCC. Further applications of the Femto include a case of microspherophakia, a very shallow anterior chamber. One can actually adjust the CCC in the center of the bag and the case can be approached very safely. Another tough case of a posterior polar cataract where there is a pre-existing breach in the posterior capsule. A perfectly rounded CCC is helpful in such cases. In this case, the IOL could be placed safely in the bag.
Nice shot!
In manual CCC, a perfectly centered rhexis on the bag is ensured by marking the visual axis and following it to create the CCC. In Femto, all of this is automated in creation of perfectly round circular CCC. Now we arrive at the most interesting topic of comparison of the strength between manual and Femto CCC. We do know that manual CCC is strong enough to hold on to capsular hooks, but manual CCC can also tear and give way in a simple step of hydro. In this particular case, an MVR nicks the anterior capsule and that particular breach is included in the boundary of the creation of the manual CCC. This is actually a weak spot. During irrigation aspiration, this is the same spot which is a weak spot. The CCC tears and it gives way. If the femto CCC is free floating, the CCC is strong enough to hold on to capsular hooks or iris hooks. But if this femto created CCC is found to have capsular tags, they act as points of weakness, and during irrigation and aspiration, this spot gives way, causing an unexpected capsular tear. Let us see yet another case of a femtorhexis having a capsular tag and the same spot giving way during irrigation aspiration. So if the femto CCC is not freely floating, it can lead to capsular tears. Adequate placement, sizing and shape in manual rhexis can be achieved by marking the corneal reflex or by following the superimposed image guided technology. In femto-assisted rhexis, all of this is automated. The benefits of femtorhexis are seen in special scenarios like a hypomature cataract, microspherophakia, microophthalmos, and posterior polar cataract. Subluxated cataracts, where we can actually move the rhexis away from the area of subluxation. While performing femtorhexis in subluxated cataract, we can decenter the rhexis away from the area of subluxation. Having said that, we know that IOL always centers in the center of the bag, and the decentered rhexis can later on be enlarged to get a perfect wraparound on the IOL. The main controversy between manual rhexis and femtorhexis is strength, but we know that manual rhexis stays intact with capsular hooks holding on, but it can give way in a simple step of hydro. Femto CCC is as strong as manual CCC. It can hold on to capsular hooks as well as iris hooks. But sometimes there are capsular tags left, which are weak spots which can give way, leading to capsular tears. Another benefit of the femto CCC is an accurate IOL centration, a less incidence of IOL tilt and decentration.
Thank you. Very well done. Kumar, brilliant. Graphics were nice. Lot of effort to make this video. Very well done. Appreciate whatever input, and should reduce the doubt in most people's mind about the stability of the CCC in a femto. Thank you. Dr. Bharti Megur, are you ready? We can have your presentation. Yes, that's right. Thank you.
I am ready, sir.
Yes, please go ahead.
Yeah.
Dr. Vivekanand, we'll have you next after this.
Okay, sir. Thank you.
Is it visible, sir?
Yes.
Anti-vitrectomy is a quintessential technique which needs to be mastered by every cataract surgeon, as it's inevitable for us to come across PC tear and vitreous disturbance. I have prepared this presentation in the form of question and answers, and I have titled this as The Whys and Hows of Anti-Vitrectomy. The answers every cataract surgeon should know. So let's begin. What's the goal of anti-vitrectomy? Is it to remove the prolapsed vitreous? No. The answer is the goal is to remove the prolapsed vitreous without causing any traction to the vitreous base. Not causing traction to the vitreous base is probably the most important goal we need to understand. Usually, out of sight is typically out of mind. It is critical for us to understand that any pull on the vitreous is going to induce vitreoretinal traction, which is not visible to us but can eventually lead to a giant retinal tear, which is extremely difficult to manage. Hence, the principles and technique of performing anti-vitrectomy are targeted towards achieving this most important goal. We also have a secondary goal while performing anti-vitrectomy. And that goal is to prevent the enlargement of the posterior capsular tear, provided it is still small, so that it gives us an opportunity to implant the lens into the bag. So what is the basic principle of anti-vitrectomy? It is to cut first and then aspirate. By cutting first, the chances of inducing any traction to the vitreous base is minimized. So cut first and then aspirate is the fundamental principle. What's the device and how does it work? Vitrector does a dual job of cutting the vitreous and then aspirating it. The motorized probe has a guillotine-like blade which moves to and fro, which cuts the tissue, and the hollow lumen inside the probe aspirates the cut tissue. So why do we need irrigation? To keep the eye pressurized so that the structures are maintained in a very normal anatomical position during the procedure. As the antechamber is well formed, it minimizes any trauma to the corneal endothelium. Well, this is the basic principle of any intraocular surgery. The next relevant question would be, is a closed chamber technique mandatory? The answer is yes. It's always preferable to have a closed chamber technique. Typically, we make two side port incisions, one for irrigation and the other for the cutter, with the main incisions, the bigger incision being sealed, either with suture or they being self-sealed. Where do I hold the irrigation cannula? It is to be held just adjacent to the side port incision which we have created, but nowhere near the posterior capsular tear. It has to be as far away from it as possible. How do we prevent enlargement of the posterior capsular tear while performing anterior vitrectomy? We all know Dr. Vasavda has beautifully demonstrated that pass-plan approach for the anterior vitrectomy greatly reduces the incidence of extension of PC tears. Can we achieve the same goal of prevention of enlargement of the PC tear, but through the anterior limbal route itself by doing something differently? Now, how can we achieve this? Number one would be to maintain the anterior chamber equilibrium at every step. We already know this. We put in dispersive OVD before removing the irrigation to prevent its shallowing. Number two would be to decrease the infusion pressure as we begin the anterior vitrectomy. We need to reduce the bottle height since the chamber is already filled with dispersive OVD. Any sudden raise in the infusion pressure inside the eye with an open posterior capsule is one of the most common reasons why the posterior capsular tear enlarges during anterior vitrectomy. Number three, segment the prolapsed vitreous into two parts. One segment which is below the level of the posterior capsule, and the second one would be above it. This is achieved by placing the cutter behind the level of the posterior capsular tear and then initiate cutting with a very high cut rate and low vacuum and low flow rate, with the port held sideways and then posteriorly so that the vitreous behind the PC is segmented away from the anteriorly prolapsed part, and later on the prolapsed anterior part is taken care by rotating the tip anteriorly. By segmenting the vitreous in two different parts, we'll be able to prevent the vitreous from behind the posterior capsular tear migrating anteriorly while removing the anteriorly prolapsed vitreous. Let us examine these points in the following few cases. We have a posterior capsular tear with a vitreous prolapse. Dispersive OVD is placed. Triamcinolone acetate placed. Time to perform the anterior vitrectomy. The first thing to do is to reduce the bottle height. The bottle height is decreased to the minimum. It is kept at 28 centimeters. The other parameters are standard, that is high cut rate, which is the highest possible with that machine, with the low flow rate and vacuum. Now, since the chamber is already filled with OVD, this low bottle height can still work as the vitrectomy is begun. Vitrector is positioned just below the level of the posterior capsular tear, and with the port facing sidewards first followed by posteriorly, the vitreous is segmented from the anteriorly prolapsed vitreous. Then the port is turned anteriorly and the prolapsed vitreous is then taken care of. The bottle height is progressively increased as the chamber is emptied of the OVD and the vitreous, so that the chamber equilibrium is not compromised. Once the vitreous is cleared off, the cortex is aspirated, and at this stage the PC tear has not enlarged. The originally planned intraocular lens is placed into the bag. Our goal of preventing the posterior capsular tear enlargement could be achieved. Case number 2. The posterior capsule is broken. We can also see an inner ring, and this is the ruptured anterior hyaloid. As the OVD is being placed into the antechamber, we can see the prolapsed vitreous finding its way towards the side port. The edges of the capsular tear are irregular and are at risk of running away during vitrectomy, thus increasing the chances of posterior capsular tear enlargement. Now let's have a step-by-step approach of managing this case. The prolapsed vitreous near the wound is first cut with the vitrector. Then the cutter is introduced into the antechamber, which is currently maintained by OVD and the prolapsed vitreous. Now first thing to do is to decrease the infusion pressure before beginning vitrectomy. The infusion is started with a bottle height of just 20 centimeters. The vitrector is placed just below the posterior tear and the port facing sideways first and then posteriorly. The cutting is begun, which takes care of the vitreous around and behind the PC tear. At the same time, the vitreous is segmented and the prolapsed vitreous in the antechamber does not have any communication with the vitreous behind the PC. The bottle height is gradually increased as and when we notice the fluttering of the antechamber, suggesting any minor compromise in its stability. The prolapsed vitreous is then taken care of. The PC tear continues to be of the same size. Before implanting the IOL, the tear is converted into a posterior capsular rhexis. The planned single-piece lens could be placed into the bag. So to conclude, we can reduce the incidence of PC tear enlargement during translimbal antivitrectomy by following the 3-point approach. Number 1, maintain the chamber equilibrium at every step. Number 2 would be decrease the infusion pressure as the antivitrectomy is begun. We need to remember that in the presence of a PC tear, the antechamber and the vitreous have direct communication. BSS from a high bottle height gets instant access to the vitreous cavity. The sudden gush of fluid will extend the PC tear even before the vitrectomy has begun. And finally, segmenting the vitreous in 2 parts by placing the cutter behind the posterior capsular tear helps us to cut the vitreous around and behind the PC tear and at the same time losing the communication with the prolapsed anterior vitreous. Dealing then with the anterior prolapsed vitreous is not going to enlarge the posterior capsular tear. So these were some of the answers to the frequently asked questions. Thank you.
Thank you, Dr. Bharti. Wonderful presentation. I guess it goes a long way for every person watching this and including the postgraduates and the young in practice. At any given point of time, the biggest heartthrob for any surgeon is that thin Lakshman Rekha of the posterior capsule. You cross that Lakshman Rekha and you're into trouble. The vitreous, the Ravan behind can come and really trap you very badly. How well you segmented it, I guess for anybody to go through it at least 10 times to understand every step that has been mentioned here. Very beautifully explained. How well to do a vitrectomy, because most people are very uncomfortable going from the pars plana area. They all want to go from the anterior area. And most often than not, it has been explained by the vitrectomy surgeon that go from the pars plana. Here, you have taken pains to explain to us that how from the anterior segment, you could segment the vitreous and you can do a vitrectomy. And mark you friends, what they have done always is to just adequately fill the chamber without putting in more fluid, absolutely low infusion, and a high vitrectomy cut rate, just enough to manage, not remove more vitreous than is desired. I think excellent presentation. We'll come back with questions due to shortage of time. We go to our next speaker, but excellent presentation, I guess. Lovely to see how well to manage the vitreous. Thanks so much for a beautiful presentation. Dr. Vivekanand, are you ready, sir? We will give it a shot once more. Thank you for being there and having the patience.
Sorry, my internet is fluctuating. So I'll share the video now, sir.
Yes, sir. Dr. Aikeda, you would be next.
In the world of ophthalmic surgery, we encounter multiple challenging scenarios. These procedures can be incredibly difficult, requiring high levels of skill, precision, and experience. We wish we had a tool as simple and strong as this. We came across the gonioscopy-assisted transluminal trabeculotomy procedure developed by Dr. Davinder Grover and Dr. Ronald Feldman. In this procedure, the tip of a Prolene suture is cauterized to create a flange, which is then introduced into the Schlemm's canal, allowing a 360-degree trabeculotomy to be completed. This led us to the path of replacing the traditional knots with flanges. Now, just like Thor and his mighty hammer Mjolnir, we too have a powerful tool at our disposal, the flanges. Our first challenge was dealing with cases of large zonular dialysis or gross zonular weakness, such as in this microspherophakia case, where a capsular tension ring alone may not provide sufficient support. In these cases, a capsular tension segment is also required. We carefully completed a rhexis and inserted the CTR. Capsular hooks were then used to anchor the back complex and phacoemulsification was performed with lower parameters. 2 sclerotomies were made using a 30 gauge needle 6 clock hours apart. One end of a 7/0 proline suture was threaded through the needle and exteriorized, while the other end of the suture was passed through the eyelet on the CTS and flanged until it was larger than the eyelet itself. The suture was pulled, simultaneously positioning the CTS in the bag, following which the suture was trimmed, flanged, and buried underneath the tenons. This procedure was repeated on the other side and an intraocular lens was placed in the eye. This technique reduces surgical time and the number of sclerotomies needed by at least half. Our second encounter, managing an iridodialysis repair. This is a case of traumatic cataract with a 4 clock hour of iridodialysis. An iris hook is used to keep the iridodialysis at bay and careful phacoemulsification is performed. After IOL implantation, the anterior chamber is filled with a combination of cohesive and dispersive viscoelastic, mainly to flatten the iris and to keep the AC formed. The extent of the iridodialysis is measured and the anchor points are marked. While moving the conjunctiva radially towards the limbus, a long spatulated needle attached to a 7/0 proline suture is inserted into the eye ab externo at the iris plane and passed to the peripheral iris with the help of a microforceps and externalized through the clear corneal incision. A U-turn is made with the same needle and reintroduced through the same incision, passed through the peripheral iris at the second anchoring point and externalized to the ab interno route. This creates a U-loop. The sutures are pulled to approximate the iridodialysis. One end is trimmed and a 1.5 mm of the suture is flanged. The other end of the suture is pulled, burying the first flange under the tenons, plugging the sclerotomy. Similarly, the other end is trimmed, flanged and buried. The overlying conjunctiva is ironed out to make sure the flanges are below the tenons. Though phacoemulsification is the gold standard for cataract surgery, in cases such as this, our options are either ECCE or MSICS. In developing countries, these cases are common, and MSICS with PMMA lens is the preferred technique. These lenses have holes in the optic mainly to facilitate IOL dialing. Inspired by Yamane and Canabrava's techniques, we developed our modification. A sclerocorneal tunnel is constructed and the cataract is extracted. A thorough anterior vitrectomy is done and the anterior chamber is formed. Displacing the conjunctiva radially towards the limbus, a sclerotomy is created using a spatulated needle attached to a 7/0 proline suture. The second sclerotomy is done 6 clock hours apart while ensuring one sclerotomy is at the tunnel site. The needles are docked into an irrigating cannula and externalized through the sclerocorneal tunnel. Once both sutures are out of the tunnel, the sutures are passed from above to below through the dialing holes of the PMMA lens and flanged until they are larger than the hole itself. The IOL is placed behind the iris and the sutures from the sclerotomies are pulled to center the IOL. Now the IOL is descended slightly towards the transconjunctival site, held close to the sclera, trimmed to around 1.5 mm and flanged. The flange is buried by lifting the surrounding conjunctiva and tenons while simultaneously pulling on the second suture. The second suture is then held close to the sclera, indenting it, trimmed to around 1.5 mm and flanged. It is as simple as that. The procedure can be performed with single-piece foldable IOLs as well by creating 2 sclerotomies, 90 degrees away from the clear corneal incisions on both the sides. The needles are docked to an irrigating cannula and brought out of the clear corneal incision, passing through the cartridge and used to puncture the broad base of the IOL haptic at the optic haptic junction on both the sides from above to below before flanging. The lens is then loaded and injected into the eye, and the sutures from the sclerotomies are pulled, trimmed, flanged and buried to plug the sclerotomies. The advantages of these flange techniques include no peritomy, no scleral flaps or pockets, minimal sclerotomies, less time consuming, easier and a quicker learning curve. Many ophthalmologists are skeptical about the use of flanges due to concerns regarding suture tract infection or endophthalmitis as a result of direct passage of the needle, flange dislocation into the vitreous due to the small size of the flange compared to the sclerotomy opening, conjunctival erosion, which could be due to a large or a fat flange required to plug large sclerotomies. We have a few suggestions to overcome these complications. Move the conjunctiva radially towards the limbus before making the sclerotomy to ensure intact conjunctiva covers the flanges at the end of surgery. Use a spatulated needle attached to a Prolene suture, which can reduce the size of the sclerotomy by more than 50% compared to gauge needles. This reduces the length of the suture to be flanged from over 3 mm to around 1.5 mm, resulting in a much smaller flange. Ensure that the suture and the surrounding area are dry before flanging. Create the flanges by holding the thermocautery adjacent to the suture tip without touching it. This avoids sharp edges that can cause suture exposure and irritation. Pass the suture from above to below the IOL, CTS, and then flange it for better stability. Approximate before the external flanging. Hold the suture with forceps close to the sclera and make a slight indentation before flanging. Ensure that the flanges are buried beneath the conjunctiva and tenons by lifting them together around the flange.
Whosoever holds this hammer shall possess the power of Thor.
The flanges have proven to be such a tool, simple yet powerful. Embrace the flanges and wield them to overcome obstacles that come your way.
Brilliant, Doc. Thank God the video played. A lot of learning for us, flanges and more flanges. I think it's a wonderful procedure. Only question I have is, over a period of time, Prolene is known to degrade. Would you be worried about it?
Yes, sir. So the knots on Prolene suture degrades from about 10 to 15 years. That's what they say. So we had a few lab tests done in the dry lab to test the strength between a flange and a knot. The flanges are way stronger. You know, when we try to pluck a flange off the suture, it is really difficult. So, and we are not crushing the suture at any point. So it's definitely going to stay much longer than the sutures, the knots.
So great trapeze artist that you have made. The flanges are the real ropes on which the trapeze artist is playing. And how much is the movement of the lens? Is there any...
Initially, that was one worry when I first tried this technique, but surprisingly, the lens does not move. It does not shake, it does not wobble. The only thing is when the flange is above the CTS or the IOL is going to get tilted. But so the flanges have to be underneath the optic of the IOL so that it is stable. It does not tilt after that.
All right. Instead of 2, if you had a 3 like a rickshaw, instead of a motorbike, you had a 3. We think that would have given you more stability?
Initially, we were thinking of having 4 flanges like a V shape. You know, we'll pass it from here, take it out there. But this is surprisingly stable, sir. You won't see a movement even if the sutures are loose. You won't see any movement when the patient's head is moving or the patient is moving in size. I don't have the video now, but we have recorded. It is surprisingly stable. And it is very easy. I'm able to train my fellows and consultants to do this. So I feel it is a very simple technique.
Thank you. Thank you so much for sharing. I mean, it definitely deserves real accolades. All the videos that we have seen, great revelation, brilliant. Jai Hindustan, you know, basically that's the story that we really have to be very proud about the kind of work that is being carried out everywhere across the country. Thank you so much for sharing your views, sir. Dr. Aikeda, over to you to look at your lovely presentation.
Yes, good evening, sir, and thank you for hosting this wonderful webinar where we get to learn so much from all of the people who have won such wonderful awards this year. And I'll be sharing my video now.
We will share our experience with the Precision Pulse capsulotomy device. Capsulorhexis is a critical step in phacoemulsification. The device being used here is called Zepto, manufactured by Minosis. It consists of a small console which is easily placed in the operating room. The handpiece attached to the device needs to be primed with balanced salt solution before using it during surgery. The capsulotomy tip consists of a soft, transparent suction cup that houses a circular nitinol ring. The superelastic properties of the nitinol allow the capsulotomy tip to be deformed mechanically into a narrow elongated shape and then re-expanded back to a circular shape by retracting back the push rod. Now let's shift to the microscopic view and take a look at our cases. Our first case here demonstrates how the precision pulse capsulotomy system works. We are creating a 2.2 millimeter incision with the keratome and injecting a dispersive viscoelastic. The capsulotomy tip is inserted by elongating it, and then the push rod is retracted back to ensure a circular shape. The suction cup is centered by looking at the Purkinje images. The movement of the water molecules tells us that we have achieved suction, and then the electrical discharge is fired, giving us a central, round, strong 5.2 millimeter capsulorhexis. Our second case here is that of a mature cataract. As soon as we apply the suction, we notice that the iris starts getting sucked into the cup. Then a series of brief, fast electrical micropulses create optimum heat to vaporize the trapped water molecules, which causes instantaneous mechanical cleavage of the anterior capsule. And that's how this device works. We then inject viscoelastic to push back the iris and examine the rhexis margin. And we can see here that we have an intact capsulorhexis. Our next patient here again has a white mature cataract and has been planned for a toric IOL. After creating the capsulotomy, we noticed that a part of the anterior capsule has not been cut. This part of the capsule was probably not in contact well with the suction cup and therefore has remained uncut. We are using Warner's scissors and rhexis forceps to complete the capsulotomy here so that we can go ahead and place the toric IOL successfully. Our fourth patient has a grade 2 cataract. We achieve a continuous capsulotomy here without any skip areas or extensions. But notice carefully that as soon as we start hydrodissection, there is an anterior capsular tear. Probably some fluid could have entered the bag after releasing the suction and the bag could have been inflated, and decompression before hydrodissection could have helped in this case. This patient has a mature hard cataract, and during the chopping maneuvers, there is an anterior capsular tear. So even though this device gives us a stronger capsulotomy than manual and femtosecond laser, we need to be careful and avoid excessive stretching of the rhexis margin. Our next patient has undergone radial keratotomy more than 20 years ago and has now presented to us with a small pupil and calcified capsule. We decide to put our Zepto system to test in this case. The device cuts the capsule on top but is unable to cleave the underlying fibrotic calcified plaque. Malidin ring is then being inserted here to enlarge the pupil first, and the fibrotic plaque is then excised with the help of micro scissors and micro forceps. The capsule is held with the forceps and cut with the scissors. IOL is inserted after completing the phacoemulsification procedure. The edge of the capsule is further trimmed safely with the IOL being in the back. This case again has a calcified capsule. We have learned our lesson from the last case, and we know that the precision pulse capsulotomy system can't cut through these capsules. So here we intentionally plan an eccentric rhexis so that the entire calcified part of the capsule lies within the nitinol ring. We achieve a continuous rhexis and proceed with the surgery. Using a precision pulse capsulotomy system is extremely helpful in these patients as it is very difficult to create a manual rhexis in a patient with calcified capsule. Our next patient has an intumescent white cataract. After creating the capsulotomy, we are unable to release the suction here. We try again to press the release button on the console, but the intumescent lens is not getting released from the suction cup even after repeated trying. We have encountered this complication in 2 more patients, and both of these patients also had intumescent cataract. So we postulate that probably the fluid pockets present in the swollen lens make it difficult for the suction to be released. Finally, we insert the dumbbell dialer under the suction cup to release the suction and withdraw the device safely from the anterior chamber. Our last case for this video is again a white intumescent cataract. And notice that as soon as we apply the suction, the anterior capsule ruptures and then extends when we are withdrawing the tip. So we have the runaway rhexis here, which is typically seen in intumescent cataracts. There is no posterior extension of the tear, and we are able to complete the surgery carefully and successfully. Now let's summarize what we have learned about the precision pulse capsulotomy system in this video. Precision pulse capsulotomy is a safe and precise capsulotomy device which is specially useful for premium IOL surgeries in intumescent cataracts, for patients with corneal opacities, small pupils, and calcified capsules. Complications like incomplete capsulorhexis and anterior capsular tears may occur. Anterior capsular tear can occur either during chopping or during hydrodissection. A gentle hydrodissection or decompression before hydrodissection may help in reducing the incidence of anterior capsular tears. The device is especially useful for intumescent cataracts, but we might have difficulty in releasing the vacuum and may encounter runaway rhexis.
Thank you, Doc. Wonderful presentation.
Thank you, sir.
Great to see different techniques by which even a fibrous capsule and a white cataract can be dealt with quite confidently. What is the indication where you will not use this?
The Zepto, sir.
Yes.
So a word of caution in patients with Fuchs endothelial dystrophy, because I still feel that the device has to undergo modification and they are trying to come up with a sleeker handpiece. So the anterior chamber depth, should be adequate to use this device. I wouldn't use it in patients who have an anterior chamber depth of less than 2 millimeters and patients who have compromised endothelium like in Fuchs endothelial dystrophy. I think those would be my top 2 contraindications to use the device, sir.
Thank you. Thank you so much for sharing your experience and some wonderful videos.
I was also wondering, sir, whether there are any studies, like she was mentioning compromised corneas, whether there are any studies which document actually how much percentage of endothelial cell loss does happen as compared to a normal rhexis.
So I think the studies regarding this device, precision pulse capsulotomy, especially when it comes to complications, are very, very few and just a few reported cases. But I don't think we have any study which talks about using this device, especially in compromised corneas. I think it is helpful in corneal opacities where the visualization is a problem, but where the endothelium health is compromised, probably because you need a specific amount of anterior chamber depth. So it might be counterproductive, but I don't think there's any published literature on that. It is helpful in subluxated cataracts, though I haven't shown that in the video, but I've used it in a couple of cases. And just like femto, we can decenter it away from the area of subluxation, and that works pretty well, actually.
Thanks so much.
Thank you,
and one more young dynamic surgeon from Bombay, Dr. Zain Khatib, is going to shows us some innovation that he has got into his technique. Over to you, Zain.
Thank you, sir. I would like to thank BOA, Lahane sir, Ragini ma'am, Himanshu sir, and Manish sir for this wonderful initiative. And I'll just share my screen. Is my screen visible?
Yes.
Yes.
So is the audio coming?
Not yet. No.
Your audio is, we can't hear the video.
Sir, can I speak along with the video?
Yes, it will be better if you speak. Yes.
So basically, this is a software that I created for topography guided LASIK. And Contura LASIK is the form of topography guided LASIK which has got FDA approval since 2016. And it had demonstrated excellent results. And when the study had come out, 65% patient eyes were supposed to do better than 6x6 vision. But then so many publications came over the years and so many different methods of doing this that, somewhere along the line, it was kind of lost. So what is the main issue we have when we plan cases for Contura LASIK? So we have this refraction manifest, which we do, and we have the cylinder, which is given to us by the machine itself. And this is the anterior corneal topography cylinder, which gets imported into the planning software. Now, there are different methods like Narayan Nitrale's protocol and Lyra protocol, which tell us that you have to actually take the cylinder from the topography and not the manifest cylinder. And what the logic is that the higher order aberrations are what is contributing to the difference between these two. So I had initially tried doing this, but then I realized that there are cases like this where higher order aberrations are very low, but still there is a big difference between the manifest and measured cylinder. So there have to be some other factors which we are not considering. It's not so simple and black and white. So, I thought about this. I tried to figure out what are the factors which lead to the difference between the topography cylinder and the manifest cylinder. And if we just study the basics, what contributes to this manifest cylinder? So you have the cylinder which comes from the anterior cornea. And then you have the cylinder which comes from the higher order aberrations, which is also part of the anterior cornea. And besides these two cylinders, you have cylinder which comes from the posterior cornea. And apart from the posterior cornea, you have the cylinder which comes from the lens itself. So all these astigmatism coming from all these individual components contributes to the manifest astigmatism. And we know the manifest astigmatism, we know the anterior corneal astigmatism, we can find the posterior corneal astigmatism. So if we have a software which can tell us how much astigmatism is coming from the higher order aberrations, then by using vector mathematics, we can find out the lenticular astigmatism. And once we know the astigmatism coming from all the components, then we can kind of, use that for our final calculation rather than just taking the anterior cornea. So this concept was first, utilized by Dr. Lobanoff in creating a software called as 4CDs, where he did the exact same thing. And to me, this was a very good software, but the only thing is it was not available at that time. I tried contacting him, but he said that it's not going to be available. So I thought that I want to use this principle for my LASIK patients for doing topography guided LASIK. So I thought I did a lot of work with coding and Excel, and finally I made my own software using trigonometry, vector mathematics, and all these things, which is called as the iSmart Contura LASIK software. So just quickly to see how we plan cases. So suppose this is a case example, we see that there is a difference between the topography cylinder and the manifest cylinder, and we can see the higher order aberrations here. Now we import all this data into our planning screen, which looks like this. So this is a Microsoft Excel based software. There's a instruction manual where we feed in all the details from the planning screen. The data from these higher order aberrations are given the name talises, and these are entered in. Finally, once all this is done, the software will tell us what is the astigmatism coming from all the individual components. So it will tell us what is the final refraction to be corrected based on all these individual components. So, how I planned cases using this software, I'll just show some case examples. Okay, so this is a 28-year-old male with minus 2.75 with minus 1 diopter cylinder at 118 degrees. And you can see that there is a superior steepening, and this superior steepening was consistent. across all machines. And this was how the planning screen looked like. And we imported this data into our software from the planning screen. And this is the individual components of astigmatism which the software gives. It shows us how much of internal astigmatism is there and gives us what is the final refraction. And this is the refraction that we feed in. And this patient, if you can see post-op day 14, how well regularized the surface has become. And with our modified refraction on the post-op day 14, he had already gained a line of vision. Now, if we look at, a second case, this is a 33-year-old female. Look at her cylinder. She has pretty high cylinders, almost 2 diopter. But if we look at the topography cylinder, it is very low. So, there's a big difference. And if we look at the astigmatism that is coming from the lens, it is again very high, more than 1. And our software told us that you have to undercorrect the cylinder coming. You have to undercorrect the manifest cylinder. And again, this patient was very happy post-operatively. And we can see the auto-ref also shows a very low cylinder. That means, the software was very accurate with its planning. So basically, this is what my software is about. And I also had a study with published data, which I had presented at the ASCRS conference. So just to conclude, this is a free of cost software. I have designed it. I can give it to anyone who's doing contour LASIK. And the biggest advantage is that it works for all cases. It works well. We don't exclude any patients. We do all of them. And constantly, I'm working on updating the results. Thank you.
Thank you very much, Jain. Brilliant. So I'm wondering whether you have also done your coding together with your calculus and physics. You learned your coding. Which language do you code? You code everything?
So just very basic Excel coding. That's all.
Good, nice, very nice. Because I think coding is the only language which the computer understands, and we all are very bad at that. And we have to depend on all these guys, young 20-year-old kids who can code it for us. Brilliant. I think a brilliant idea to get your thing going and put your own software for one of the most acclaimed procedure right now that we have, Contura LASIK. Thank you all participants. Dr. Lane, sir, a few words from you. Dr. Ragini, good to see you. Good evening. How are you? Kem cho ben? Nice. Sir, you're on mute.
Yes. Hello. Good evening.
Good evening.
I'm really very happy and the initiative by the Himanshu and Monish, because the Bombay Ophthalmic Association has called all our, you can say, the award winners. And I'm really happy to see everybody. In between, I was unable to join. But later on, once I joined, I saw, see, our talent is better than anywhere in the world. I really appreciate our innovation, and that our innovation is the best. And not only one thing, but you will see the efforts behind every video, efforts behind every innovation, and the time consumed for that. Really, and I think everything, without a small lacune also, they have presented this. I appreciate everybody. All 11 out of that, I think 7 have presented here. And really, I'm very happy. And I appreciate and congratulate everybody. I want our research, our university. Again, I think next year this time it is 11. Next time we should go to more than that. And the grand winner is also ours, and other winners are also ours. So I think I appreciate everybody, and I think this our science should grow. Our BOA members, I think the Kumar and Jain and also the Mehra. So I think they have also done wonders. Ekida also, they have done wonders. So I think and this Deepak also is there. So I really appreciate efforts of each and everyone, and I congratulate my team. That is Dr. Ragini, Dr. Himanshu, and Dr. Manish. Good work and very good thing you have done. Thank you very much.
Thank you all participants, and I really hope that all those guys who have missed this wonderful session take the time off and see what they are missing out. This is an absolute treat in ophthalmology. Some of the best brains showing the best, and a lot of efforts to each one for having created this wonderful video. Not only having taken the risk to do all those complicated cases, but having had the time and the patience to edit and make it so good to have a final prize there. Kumar, you wanted to say something? Yes.
Just a little word about the grand prize that was won by Arvind, which you were there and you were sitting, which we saw the whole film. Just for the audience, I want to let them know that they talked about wastage per day in a cataract surgery in the US and in India. So it is unbelievably different, and it just shows that the way that the Indians are doing by not wasting unnecessary tips, like all of you know, or some of you may not know, that per each case in the US, they spend one tubing, one tip, one sleeve, everything is thrown away, and one whole set is thrown away after surgery. And they actually weighed it, and I think they have 6 kilos of wastage per day in cataract surgery in one center, while Arvind had hardly a few grams. So I think that video is phenomenal. Some of you who have not seen it should make an effort. It's an eye-opener as to how much wastage is happening, and it's nice that it's come out from India, from Arvind, to open the eyes of everybody. Still, I don't think changes are going to happen in the US, but it's glad that it's come from India.
Yeah, Dr. Susan has just managed to join in. Susan's daughter's birthday was there. She was treating her daughter for that. Happy birthday to your daughter, Susan. And we are waiting for you. Most of the other speakers have, thanks for joining last minute. So we would love to see your video. It's a beautiful video that you have. And thanks. Over to you.
Thank you so much, sir. Please just give me a minute, sir, if you don't mind. I'm just going to...
Nice to see you, Susan. You are in India. That's a good news.
Very much in India, sir. Sir, is there anyone else who has to present, sir?
No, we were just winding up when you joined in. Absolutely. But we will do the talking. We'll do the chatting.
If I may add, I think,
Rohit.
Yeah, what is the best part about all these winners? That half of them or more than half of them have, standalone practices. And when you have standalone practices and still you are able to come out, it requires, they say that when you have to make a movie, it takes a year because you have to plan out things. Everything has to go with it. So I was with Ronald Yaw, and he said, before ASCRS, I met him, and he said that he has already thought about the movie which is going to show for the next year. Dr. Kumar will vouch, for that, because he also plans things. I think it was his third winning of the video.
Yeah. Yes. Susan is ready, I think.
Yeah, Susan, go ahead.
Can I just go ahead and play the video, sir?
Yes.
Just 1 second.
Dr. Jacob has a patent pending for special trifines, modified care segments, and some of the other devices shown. None of the other authors have any financial interests.
We can't hear the audio, Susan.
Oh, okay. I am not sure why that's happening, sir. Can you hear me?
We can hear you, so fine, great.
Allogenic intrastromal ring segments pairs.
Now we can hear.
As to the intra-channel placement of allogenic tissue and is used to treat corneal ectasia. As the name implies, it refers to allogenic tissue of any source that may be used in this manner and can include, among others, fresh-cut cares, unprocessed or processed cares, preserved or packaged cares with or without modifications, and with or without storage and shelf life capabilities. CARES is traditionally used as standard, longitudinally cut, uniform thickness segments. However, we have also described customized CARES for further refining the results of CARES treatment. Customization allows the effect of CARES to be tailored to the individual keratoconus stage, providing better topography and refractive results that are more tailor-made for each individual patient. Synthetic symmetric intracorneal ring segments, ASCRS, have been used for keratoconus since many years. We too have previously described very encouraging results for symmetric, uniform thickness CARES in keratoconus, with patients showing significant improvement in almost all the parameters studied, such as uncorrected and spectacle-corrected distance visual acuity, spherical equivalent, topographic astigmatism, maximum and steepest keratometry, best fit spheres, etc. As described previously, these are longitudinally cut allogenic segments of uniform thickness that are similar to intacts. Though we obtained good results with standard uniform thickness CARES, the possibility of tweaking the results still further by customizing CARES to the individual patient's topography and refraction was an exciting one. We therefore used customized CARES in patients with asymmetric keratoconus. This was done by shaping CARES according to their topographic and refractive needs. The uniform thickness CARES was marked, and using a special CARES customizer instrument that we designed ourselves, we were able to mark the segment according to the desired optic zone and degree or clock hour. We could then cut the exact shape that was required according to the patient's keratometric gradient and then insert it intrastromally into the patient's cornea. Customized CARES includes asymmetric or symmetric, specifically shaped CARES that are prepared, and these can be of progressive or variable thickness, progressive or variable width, or combinations. In addition, change in shape or transition zone can be created to have sudden change or gradual taper, and variations in shape or thickness may be along a defined extent or along the entire arc length. As obvious, in progressive ectasias, CARES is combined with corneal cross-linking to stabilize progression. We customized CARES by first trephining standard CARES using a special double-bladed trephine, placing the standard CARES segment on a computer-printed degree zone marker, followed by marking the required arc length and transition points with a fine-tipped inked marker. We soon got this pattern stamped on an autoclavable instrument to facilitate customization surgery further. This was then placed on a flat cutting surface, for instance, a Teflon block, and cut with a sharp blade using the transition marks as reference points. We found that it gave us excellent predictability with the hand-cut segments matching well to the surgical plan. We also found it easy and quick to customize once the marks were applied to standard CARES. For surgeons desiring freedom from preparing customized CARES, this could be done by an eye bank technician or in the future using the femtosecond laser. Once the customized CARES are prepared, they are inserted into femtosecond or manually dissected channels in the cornea. Just as for standard CARES, we continue to use wider tunnel settings together with shallow implantation. The usual settings we employ are an inner diameter of 4.6 mm and outer diameter of about 7.1 mm, with tunnel depth programmed to be at 50% of minimum stromal thickness in zone of implantation. CARES per se has numerous advantages over synthetic ICRS. For one, the allogenic nature of the tissue decreases the risk of some of the complications associated with synthetic ICRS, such as stromal melting, necrosis, intrusion, extrusion, migration, etc. If Kmax is more than 58 diopters, or if minimum corneal thickness at the zone of implantation is less than 450 microns, or if the mesopic pupil size is more than 6 millimeters, synthetic ICRS is generally contraindicated. However, CARES can be implanted in all these situations because of the allogenic nature of the tissue. This avoids anterior stromal necrosis, a smaller optic zone, implantation of thicker segments, allowing greater volume change, and superficial implantation all allow greater effect from CARES as compared to synthetic ICRS. CARES also gives the ability to use smaller optic zones since the risk for photic phenomena, glare and halos from CARES is low as compared to ICRS. CARES, being allogenic, would not carry the risk of corneal melt, and in fact has been used by us to treat post-intact melt. A synthetic ICRS, however, even if placed at an acceptable depth initially, may still cause melt because of the synthetic nature. Progression and eye rubbing can worsen this risk further. We use the manual trephine to cut and customize CARES. Altering the distance between the two blades alters the volume of tissue cut. The femtosecond laser can also be used for creating custom CARES. It can very accurately customize the arc length, the degree of taper, as well as the thickness and depth of the CARES, adding exciting new possibilities in harnessing CARES further. More extensive customization by varying shapes further using the femtosecond laser is being researched further. Since CARES can be customized on spot, large inventories are not needed. Unlike the synthetic progressive thickness ASCRS, which come in only fixed sizes and proportions, making true customization impossible. This is unlike CARES, where exquisite customization of any pattern is possible. For instance, unlike synthetic progressive thickness ASCRS, we did not use uniform end-to-end taper, but chose the location to correlate with topographic pattern. Different customized shapes can be employed, some examples being single side taper, double side taper, central taper, connecting band shape, etc. To conclude, custom CARES is an addition procedure that can be used successfully for mild to advanced cases of keratoconus and post-LASIK ectasia to improve topography and vision. Decrease in coma and other HOAs improves distorted vision. In combination with CXL, it can help avoid dark in many patients. The future, we believe, will see more and more use of customized CARES.
Thanks, Susan. Brilliant. I think CARES would take over any kind of intacs that we might ever see.
Thank you so much.
It is the genuine organic answer to anything else that we can see.
Thanks a lot, sir. Actually, I've been doing customization for some time now with the manual Trifine, and it gives very good customization using the CARES customizer marker and all. But about probably 7 to 8 months back, also with Dr. Kumar sir, in his clinic, we also did with the Zymer laser, customized CARES, and I was very happy to have had that honor of working with both Zymer and Kumar sir, and that's another thing that's also coming where you can customize using the femtosecond laser also.
Thanks very much again, every participant.
The Himanshu, I forgot Rohit and now Sujan. So really, the Sujan and Rohit did wonders, and congratulations. Thank you very much. And Bharti, I took name Bharti. Okay.
Yes, thank you, sir. Your blessings are always with us.
Yes. Rohit, and I have just seen your presentation, and I think it was wonderful. 1, 2, 3. A, B, C. Excellent.
Yeah.
Appreciate.
Yeah.
Okay.
Thank you, sir.
Dr. Vivekanand also took the time off and showed a wonderful presentation. Thank
Yes, I saw that also. Also Vivekanand. I forgot Vivekanand's name.
Yes, sir.
Thank you.
Thank you.
And Navneet, please come in front. Thank you for your unhindered support, for screening the whole thing so beautifully and coordinating the whole event.
Thank you very much, sir. Pleasure to us. Thanks a lot, sir.
Thank you, Microvision.
Ragini is saying thanks to everyone.
Thank you everybody, and congratulations.
Thank you so much, and
Thank you.
good night, Fred. We wind up today with a promise that we'll be coming back very soon with some of the top winners and the best of the techniques that we can do to increase our understanding of ophthalmology and see that Jai Hind, India gets even more unique in its own way. We have huge volume. Nobody in the world can really come anywhere close to what we can do in this world. Thank you all participants, with a great note to see more prizes coming up for all the ESCRS, ASCRS and the APSCRS in the future. Thanks very much for participation.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you.
Thank you, sir.